welcome to the FlightBridgeED Podcast series. Hey everybody, Eric with you with FlightBridgeED. This afternoon we're going to do something a little bit different. We're going to go through kind of a critical care roundtable discussion on a few cases that I've come across in the last few months from different flight crews in the industry in this area. And so I think it's fitting that we look at some cases every once in a while, kind of apply the different pathophysiology, the different treatment modalities that we could take in each of these circumstances, and try to apply what we've learned in the last 12 months that we've been putting out podcasts and apply some of the things that I've taught. So before we do that, I want to thank everybody for following us on Twitter, on Facebook, for getting involved and downloading our podcasts, for purchasing our books that the book that we've published, for registering and coming to our review classes. Without you, we wouldn't be anything. And like I've said many times, this has been one of the most rewarding, if not the most rewarding thing I've ever done in education or in my EMS career. So thank you so much for making this such a great experience. All right, so the first thing we're going to do, I'm going to break down this scenario. This is, again, a real patient flight, and we're going to break it down. We're going to talk about the different aspects of her presentation, and we'll kind of go from there. So we'll start off. You have a 21-year-old female patient that was brought into a small facility ER by EMS. She was found down by her family. Downtime probably 24 to 48 hours. This patient has a long history of anorexia, bulimia, and is a non-compliant insulin-dependent diabetic. She had an initial GCS when she was found of about 12 to 13, and she had Kussmaul respirations anywhere from 36 to 40 at that time. When you arrive on scene, the flight crew visually witnesses the RT bagging the patient via end-tidal CO2 waveform capnography on an ET tube. She's been intubated. The report states that she was maintaining a rate of about 36. She was very obtunded, and then she had a decrease in mentation, and because of that, they chose to intubate her. RT is continuing her bag valve mask ventilations at a rate of about 30 to 36. And the referring nurse gives you a report and gives you labs. So her current labs at this time, she has a sodium of 186. She has a hematocrit of 68. She has a potassium of 2.1 and a serum Oz of 350 with a glucose currently at 891. All right, so before we kind of go into this, let's kind of decipher just those labs because I don't want to get too far in depth without going through each one. A sodium of 186. Remember, your normal sodium level should be around 135 to 145, in that range, depending on the textbook that you read. Her hematocrit is 68. So remember, the higher the hematocrit, the drier the patient is, and a hematocrit is essentially the concentration of the blood. How concentrated is the hemoglobin compared to the fluid? Your potassium of 2.1, that is very, very low. That's actually critically low. A serum osmolol is a reflection of cellular hydration. So the higher that number is, the more dehydrated intracellularly the patient is. So a lower serum Oz is going to mean that the patient has a better hydration status. So just based on the sodium, hematocrit, and the serum Oz, all those should be telling you that the patient is extremely dry, or as my colleague in Kentucky says, Tony Harrison says, dry as toast, which always makes everybody laugh. And then she has a current glucose level of 891, and so we automatically know that she is probably in DKA with a sodium of, or I should say with a glucose of 891 and her potassium being as low as it is. She also has a current ABG, and so we'll kind of go through that really quick. Per the RT, the current ABG, she has a pH of 7.25. She has a CO2 of 16, a bicarb of 12, and a PaO2 of 88. All right, so let's go through this again. Our pH is 7.25. That's going to be an acidosis, right? She has a PaCO2 of 16, which is low. That means she's blowing off all the acid. She has a low amount of acid, and she's doing that, remember, because she's trying to compensate. She's trying to blow off the acid. And she has a bicarb of 12. Well, the bicarb of 12 is also indicative of we have not enough base, right? So we have a metabolic acidosis. And then she has a PaO2 of 88. PaO2 of 88, that's in a normal range. That means she's getting enough oxygen to the tissues at this point. Okay. So further on in the report, you're told that the patient has been on an insulin drip the last 2 hours. They started her on an insulin drip at 11 units an hour. She's like I said, anorexic, and she's only 40 to 45 kilos in size, so she's very tiny. You and your partner do a good assessment, and you check another blood sugar, and you note that the blood sugar now is currently 200. So in 2 hours, she has a drop of serum glucose from 891 to 200 in just a few hours. And so why is that? Well, the big thing to look at here is when we look at dropping a person's glucose in DKA, we got to remember that in an ICU setting, you never want to drop a glucose more than 100 an hour, ever. And that's in a setting that's very controlled. So for purposes of flight and what we do in the HIMSS industry, I'm not concerned as an educator, as a flight paramedic, of even worrying about dropping that glucose. That's something that's kind of last on my mind. Obviously, you need the insulin. Insulin is good to try to counterbalance the ketones that are being released and things like that. But that's kind of the last thing, because I'm going to be very worried about dropping that sugar too fast. And that's exactly what she's done. Remember, like I told you, she had a GCS of 12 to 13, and then she became very obtunded very quickly. Well, why is that? It's because her sugar dropped from 891 to 200, and essentially she has a hydrocephalus now. She has this massive fluid influx into her brain, and she has this cerebral edema, and that's a secondary result of dropping that sugar so fast. So where should her insulin been? Well, a good standard dose for insulin would have been about 0.1 units a kilogram an hour. That would have been a good range for her. So with her weight being 40 to 45 kilos, probably no more than 4 to 5 units an hour would have been probably a good dose for her. With it being checked continuously, right? You start seeing that drop too much, you need to be slowing that down. Like I said, insulin is great because it's going to be important to counterbalance all those ketones. And so another adage would be maybe to start, D5.5 or something like that to kind of counterbalance that. And that's often a strategy seen in the ICU to maintain the insulin at a certain level, but don't bring that sugar. That's a normal strategy seen in the ICU, where you would give maybe D5.5, and you would keep that insulin at a moderate rate to counterbalance those ketones and to maintain a sugar level that was going to be adequate, so you wouldn't cause that cerebral edema. Continuing, she has a trace amount of urine output, so she has very little to no urine output. So that's kind of a big problem. Remember, a peeing person is a somewhat stable person per se. That means that person is perfusing. And so if you have a patient that is so dry, and we already saw based on the labs of a sodium of 186 and a crit of 68, those two right there should tell you the patient is extremely dry. So she has no urine output. So remember, we kind of go back and we have this potassium of 2.1, and this is kind of the big aspect of this whole thing that you should have taken from the initial labs. Out of all of these things that I listed off, that potassium of 2.1 is extremely critical. And some things to remember about potassium is that a high potassium, although is very hard on the heart and can cause some irritability and some arrhythmias, you can bring down that potassium a lot quicker, and you can manage that. A patient that has a potassium that's extremely low like that, and oftentimes you see this in a DKA patient that's extremely dry, they've been peeing all this off, and so they've depleted all that potassium out, and they've also driven all that potassium that would be in the blood into the cells. So it's either a shift into the cells, or they've peed it all off, and you don't really know which is which in this situation. So the big aspect here is, how do you treat the potassium? We've got to treat the potassium somehow. And we know a DKA patient, the biggest thing they need is volume. They need to be fluid resuscitated. So we have two problems here. The patient needs to be fluid resuscitated. You have a potassium of 2.1, and so if you give them a lot of volume, and remember, DKA patients need liters and liters of fluid, 5 to 7 liters sometimes, even more. What you're going to do is you're going to dilute that potassium out even more, and you're going to cause it to drop even more. So you kind of are in a pinch here. We've got to treat the potassium, but we also need to worry about dropping it too much. The secondary aspect here is the urine output. And here's the argument, and you're going to get two different mindsets here. You're going to get an intensivist, maybe a level 1 ICU, say that he's going to wait on administering potassium. You're going to get a ER physician that's going to say treat the potassium, and here's why. Because the adage is if you don't have any urine output and your kidneys aren't perfusing appropriately, they're not producing urine, and you give all this potassium is absorbed, or reabsorbed, I should say, in the kidneys, and then utilized and transferred into your muscles and things like that, into your bloodstream and your cells. If you don't have urine output to do that, then you're not going to utilize that potassium correctly, and it's just going to sit there. And so there's two different mindsets there. Do you treat the potassium, or do you not? Do you give them enough fluid volume to get their urine output adequate and then start treating the potassium, and then risk dropping the level of potassium down to a critical low and putting them into an arrest, or do you treat it? Here's the way I kind of would play it. I would look at it, and I would probably give them a couple runs of potassium, and I would do it PO. I would put an NG tube down or an OG tube down. I would give them 20 to 40 milliequivalents down PO, and I would start volume resuscitating. I think for me, and again, I'm not a physician, but for me, I would tend to want to play it safe. To me, dropping the potassium even more is going to be a bigger deal than maybe worrying about the kidneys. And so I think I would rather be on the safe side, add potassium, maybe do KPhos, because the phosphorus is also going to be low in that situation. Give KPhos, and then start giving a lot of fluid resuscitation in the meantime. And so that's how I would play that. Again, there's two different kind of mindsets, two different ways to look at that. And I think it's important to look at those other things. Continuing, her actual BUN and creatinine were normal, so she had good kidney function. It was just a problem with volume. She was extremely dry, so she didn't have any acute renal failure. She didn't have any chronic renal failure. No kidney problems whatsoever. All right, so let's kind of recap this. So our 21-year-old female, she's a history of anorexia, type 1 diabetes that's non-compliant. And we go back to our blood gas. And our blood gas, we would think her pH would be extremely low in this situation. But you got to remember that an anorexic patient sits in an alkalotic state. They're always alkalotic. Their pH is going to sit a lot higher because of all the vomiting and diarrhea and things like that. So her pH of 7.25 to me is higher than what I would expect. Her PaCO2 is low, remember, because she's blowing off the acid. She's trying to blow off the acid. That's the only way she can kind of compensate in this situation. And then her bicarb matches. She's in that metabolic acidosis. All right. So how are we going to treat this patient? Well, we talked about her sodium is 186. Her sodium is high because sodium, again, it's a concentration based on volume. And if you're volume depleted, the concentration of sodium compared to the volume is higher. And so if we start fluid resuscitating her, her sodium is going to drop down into the normal range. Her hematocrit will do the same thing. So I'm not too worried about those two things. Her serum Oz, again, is going to correct itself with the volume. So again, we're left with the potassium. We've got to treat the potassium. Again, that's my view on that. I would give runs of potassium, PO, KPhos, and do a maintenance infusion of 10 milliequivalents an hour with phosphorus added to it. to try to, maintain a good potassium, bring that up. And you're only going to bring that up probably, to 2.1 to 2.3 after that first run. I mean, it's not going to be a huge jump. The other thing to remember here is that your sugar dropped from 891 to 200. And if it dropped that far, what do we do with that insulin? Here's the other aspect. Do you shut the insulin off, or do you continue it? Do you reduce it to a normal level that would match her weight to 4, maybe 4.5 units an hour? Or do you shut it off completely? Remember, your insulin needs to be there to counterbalance those ketones, to deal with those ketones. That's important. But your sugar has already dropped so much. So again, here's the argument. Do you shut off the potassium, or do you shut off the insulin? I would say in this situation, you probably would until you could get a good handle on that sugar. You would want to make sure that sugar didn't drop anymore. And this patient actually, they did another sugar in flight after shutting the insulin off, and the sugar was down to like 105, 106. So it had dropped even more. So in this patient, I feel because you have such a massive drop from the original 891, you're down into the 105 range after just 2.5 hours. Shutting the insulin off would be a must, just to make sure you didn't cause that sugar to plummet down into the severely low range. All right, so now how are we going to treat this patient in flight? Her blood pressure is about 86/40, so she's hemodynamically unstable to a point. Her pulse rate is 130, so she's tachycardic. She's still compensating in that way. So is the volume going to correct the blood pressure? I would argue yes. I would probably not start this patient on any type of pressor yet. I wouldn't worry about that. So how are we going to treat this patient's airway? What ways can we use our ventilator to help correct this problem? So here's kind of the way I would play this. This patient's 21 years old. She's young. She has no signs of hypoxia on her blood gas. And so I would use standard settings. I would use an SIMV because remember, in a metabolic acidosis, the patient's compensating by blowing off the CO2. They've got Kussmaul respirations, and it's very important to look at that and realize they need to maintain that. And so a good way to look at that is look at that blood gas CO2, which I believe it was about 15 or 16. Match that with end-tidal CO2. If it should be pretty close, within 3 to 5 points, and then maintain that end-tidal CO2 throughout transport. So whatever you have to do to set your rate at a range that's going to maintain that CO2, or end-tidal CO2, I should say, at that range, that 15 to 16 range, that's going to continue to allow her to blow off enough acid and continue that compensatory mechanism. Remember from earlier podcasts, there's a correlation of your CO2 and your pH. And that correlation is for every 10 points that CO2 rises or falls, your pH is going to do just the opposite, and it's going to change by 0.08 in the opposite direction. So let's kind of do one real quick. If we were to increase her CO2 from 15 to 25, her pH would drop by 0.08. So if her pH is 7.25 now, it's going to drop to 7.17, right? We have a 10-point increase. We're going to drop by 0.08. So her pH would actually drop in the wrong way. So that's why we never want a patient in metabolic acidosis to have a low rate. We always want to make sure that rate is high so we don't have that precipitous drop in pH that's going to cause bradyarrhythmias and arrests and things like that. So some important things to remember. This patient should be put on an SIMV mode of ventilation just because it allows them to have that compensatory rate on their own. They could still overbreathe the ventilator. Volume or pressure, I would start your patient on volume. You can get a plateau pressure in that way. Again, she's not hypoxic. She has no lung injury, no lung disease, so I really don't feel like pressure would be warranted. So tidal volume. Tidal volume, again, needs to be at a range between 6 to 8 mils per kilogram. I always start at the low end. So if she's 40 to 50 kilos, 40 to 45 kilos, a tidal volume range around 300 would be a good starting point for her. Now her rate, remember her compensatory rate on her own was around 36, so I would immediately match that. So I would put her rate around 36. FiO2, well, remember her PaCO2, or I should say her PaO2 was 88. So she's oxygenating fine. So you could start off with an FiO2 of 100%, and I would immediately dial that down as low as possible to maintain a SAT of 92 to 93%. Remember, on all SIMV patients, we always want to add pressure support. Pressure support is that augmentation for when they take that spontaneous breath. So we would add, let's say, 10 of pressure support. And then PEEP is always a good thing. Intrinsic PEEP is around 3 to 4 or 5 centimeters of water, so I would start at 5 of PEEP on this patient. And that's how I would play the ventilator in this situation. We have we've shut off our insulin. We're giving volume. We gave a run of potassium PO, so 20 milliequivalents, 20 to 40, let's say, before we left. We started a maintenance infusion of KFOS for in flight. I would also, with this precipitous drop in sugar, I would probably also start D5.5 just to make sure that we got something going so our sugar doesn't drop even more. And then we just need to try to deal with this patient the best we can. We need to constantly reassess. We need to be looking at our pressures on the ventilator. We need to be looking at our PIPs and our P-plats. We need to be assessing her sugar constantly, make sure that sugar doesn't keep dropping, and try to prevent any further harm. Now, again, remember, urine output is everything, so obviously a Foley would be a great thing to place before we left the receiving facility. From earlier podcasts, you know I'm a big advocate on getting off scene as quickly as possible. This patient is a train wreck. This is an extremely complex patient that we have presented to many physicians, and they have felt very overwhelmed with this patient. So this is a tough patient. There's a lot of things going on. Again, I want to thank everybody for following FlightBridgeED. I want to thank you for just making this such an enjoyable experience. I want to remind everybody that we do have our book that's for sale on the website, or you can find it on Amazon.com. It's a full-color 205-page book that encompasses everything critical care that will prepare you for the CFRN, FPC, CCRN, CEN. It's got rationale. It's got test questions. It's got test tips and things like that. So you can find that on FlightBridgeED.com or Amazon.com as well. We also have our test bank. We have our practice exams, $79.99 for 3 attempts. It's well worth the money. They're very hard exams. It's going to give you the rationale after you miss a question at the end of the exam, and we've had great feedback on that, and we've had a high success rate from people taking our exams. So that's all I'm going to have for today, and I look forward to talking to you guys soon on the next podcast. Have a great day. We want to thank you for following FlightBridgeED.